Hi, I'm Dr. Jennifer Mercer, a consultant obstetrician gynecologist and chief of the Department of Obstetrics and Gynecology at Central Newfoundland Regional Health Centre.
And my name's Dr. Robert Brooks, family physician, GP obstetrics.
As part of the Managing Obstetrical Emergencies in Rural and Remote Centres, we are very pleased to bring to you today a presentation regarding preterm rupture of membranes and preterm labour and delivery.
So we're going to begin this lecture by reviewing a few specific objectives that we plan to cover. So we're going to cover preterm labor and delivery and preterm pre-labor rupture of membranes, in particular the causes and incidence of these conditions, tools that we can use to predict preterm labor, including fetal fibronectin and transvaginal ultrasound. And then we'll be reviewing specific treatment options to prevent and manage preterm labor, and this will include things like steroids, tocolytics, and transfer criteria. So, unfortunately, the incidence of preterm labor has been increasing in Canada over the last many years. So from 6.3 about 20 years ago to now 8.2 in 2004. The good news is that survival is actually very good above 34 weeks, with 99 to 100% of babies surviving. Below 34 weeks, thankfully, is a rare occurrence. So only 1 to 2% of preterm deliveries happen before 34 weeks. Survival over this time has increased over the last 20 years, and that's due to improvements in obstetrical and neonatal care. And as we'll see in the next few slides, that early gestational age are associated with the highest risk of mortality and morbidity. So this slide just puts us in context. So Newfoundland has a rate of about 8 in 100 live births, which puts us near the top of the country, third place in fact. And as 8 in 100, though not frequent, it's also not rare and will likely present in rural and remote locations. So, in terms of infant mortality, you can see here again, as gestational age decreases from 37 weeks, we have a dramatic increase in mortality. This slide really, to me, stresses the importance of accurate dating. In fact, the SOGC guidelines now recommend that a first trimester ultrasound be recommended to all patients between 11 and 14 weeks. And the obstetricians here in Central Health offer this services to all patients and recommend that you refer all patients for a first trimester ultrasound to ensure dates are accurate. For example, you can see here the difference between 10 days between 23 and 24 weeks can be a difference in survival between 30 and 60%. Substantial. It's important that every woman know her gestational age in the first trimester. So, what are the causes of preterm birth? Well, basically divided into 4 categories. So, you have preterm labor, that's associated with intact membranes. You have PPROM, or the preterm pre-labor rupture of membranes. And then you have indications, so maternal and fetal indications for delivery, such as preeclampsia, and then multiples, twins, triplets, and such that always deliver generally preterm. So who should you be worried about? Well, in terms of risk factors, the number one risk factor is that they've had this before. So preterm birth is the greatest risk factor. Reoccurrences tend to occur at the same gestational age, and as you can see on the slide here, that it's highest when you've had multiple preterm births. So by the time you've had 3, you have a 67% chance of having another preterm birth. The reverse of this is also true. If you've had a term birth, it's less likely that you're going to go on to have a preterm birth. So in terms of other risk factors that you should just be thinking about, so ART stands for Advanced Reproductive Technology. You'd be worried about in the settings of antepartum bleeding, PPROM. Cervical and uterine factors. These are things such as previous leaps, congenital abnormalities in women's uteruses. And fetal and intrauterine factors include things like polyhydramnios and fetal anomalies. The one that I always think about when people present in a rural location is infection, and chorioamnitis is a common cause. And demographic and lifestyle factors, these are things that are often difficult to change but put women at risk. So for example, low levels of education, single women, maternal age less than 18 or over 35, and things like smoking, poor weight gain in pregnancy, and illicit drug use. So what can we do to prevent preterm labor? So specifically, as family physicians and physicians working in a rural environment. To prevent it, we can encourage smoking cessation. This is associated with preterm labor, and if we can convince our women to stop, it is suggested that this will decrease its incidence. We can also try to encourage women to stop any kind of maternal substance abuse and refer them to useful services. Again, this is associated with preterm labor. If we can avoid short interval pregnancy intervals, so again, this speaks to your postpartum visit with women to ensure that they have appropriate contraception. And again, just having prenatal care, the absence of prenatal care is related to preterm labor, though this is not necessarily causal. It just again stresses the importance of our role in prevention. In regards of active things we can do, so we can screen and treat for asymptomatic bacteriuria. This should be completed in all women, particularly if they have a history of preterm birth. The numbers in terms of when we actually treat, you can decrease the risk of pyelonephritis from 20 to 30% and down to a range of 1 to 4%. And not only does it decrease the risk of pyelonephritis, it decreases the risk of preterm labor. So you screen, treat, and if you've treated, you recheck to make sure it's cleared again. The second thing we can do is screen and treat for bacterial vaginosis only in women who have had a history of preterm births in the past. If prevention is taken, adverse pregnancy outcomes can be avoided, and this can be reviewed in detail in the SOGC guidelines, but can be treated with metronidazole orally twice daily for 7 days. There are other options that can be reviewed at your leisure. So, what kind of things can we use, or what tools do we have to determine the woman who shows up with possible preterm labor, to determine if they're actually in preterm labor or not? So the useful tool for us is this fetal fibronectin. So again, this is a protein that is, when it's found in cervical vaginal fluid, is associated with preterm birth below 34 and 6 days. So the main benefit for this test is its negative predictive value. That means a negative test is useful. So when we do the fetal fibronectin and it's negative, the chance of having a preterm delivery in the next 7 to 14 days is around 1 to 2%. So we've ruled it out to 98, 99%. There are a few things that you have to have and things you can't do that are important to actually do the test correctly. So if you're thinking of doing this test, you have to ensure that you have not performed a digital exam, as this disrupts the service of the cervix and throws off the test. In fact, you need to ensure that the woman hasn't ruptured and that there's no cervical dilation, so the woman is not in actual labor. And is only appropriate from age 22 plus 0 to 34 and 6 weeks. Contraindications, so I always ensure that the woman has not had vaginal intercourse in the last 24 hours, no use of lubricants, and again, no PV bleeding or rupture of membranes. This is useful in symptomatic patients who we're not sure if they're in preterm labor. Again, it's useful to rule out preterm labor and to use this test in the right circumstances so we can avoid expensive interventions and transport. And just finally, just briefly to talk about how to do it, because again, if you don't do it right, it's not useful. So this should be, you use a sterile speculum. I usually use warm water without lubricant. You expose the cervix and place the swab into the posterior fornix, and you leave it there for 10 seconds, gently rotating. It's then removed, placed in the bottle, and tightly sealed so it doesn't spill, and then sent to the lab. I'll now hand over to Dr. Jennifer Mercer, who will be reviewing the management options in preterm labor.
Transvaginal ultrasound is one of the tools that we use with increasing frequency to assess a patient's risk of preterm labor and delivery. We know that as the cervical length decreases, the risk of preterm birth increases exponentially. Assessing the cervical length somewhere between 16 and 28 weeks is the best predictor of risk of preterm labor and delivery. A cervical length of less than 25 millimeters or 2.5 centimeters is consistently associated with an increased risk of preterm birth. Cervical length shortening usually occurs slowly and precedes labor by several weeks. Current guidelines suggest that for asymptomatic patients less than 24 weeks who have known risk factors for preterm birth, so for example, those with a history of preterm birth, those who've had procedures of the cervix, including LEEP excisional biopsies or cone biopsies, patients with Müllerian anomalies or uterine anomalies, or patients who have had a previous dilatation and evacuation greater than 13 weeks gestation, they should have a cervical length assessment sometime before 24 weeks gestation. For those women with prior history of LEEP or cone biopsy, generally at our center we're seeing these patients somewhere between 16 and 22 weeks and doing a one-time cervical length assessment. If the cervical length assessment is normal at that visit, they don't require any further surveillance. However, patients with a history of prior preterm birth, we know that they are at the highest risk for preterm birth in the current pregnancy, and therefore for those patients, we often will start seeing them somewhere between 6 and 8 weeks prior to the gestation at which they delivered in their previous pregnancy, and follow them serially with repeat transvaginal ultrasounds for cervical length every 2 to 3 weeks thereafter. We have begun to use progesterone for women with increased risk for preterm labor and delivery. We know that administration of progesterone within the second trimester significantly decreases the risk of preterm birth. Progesterone is currently indicated for women with a history of preterm birth and for those with a known shortened cervix. SOGC guidelines currently suggest that patients at increased risk for preterm birth should be encouraged to participate in progesterone trials. They need to be informed about the lack of available data on neonatal outcomes. However, progesterone should be used in women with a previous preterm birth or those with a shortened cervix less than 15 millimeters at 22 to 26 weeks gestation. Obviously, a decision to administer progesterone to a patient to decrease the risk of preterm birth is done in conjunction with a consultant obstetrician and often with the maternal fetal medicine specialists at the tertiary center. Now we're going to talk a little bit about the treatment of preterm pre-labor rupture of membranes and preterm labor. Keeping in mind as we go through these slides that as a physician in a rural center, seeing and assessing a patient with suspected PPROM or preterm labor, you would not be expected necessarily to institute all of these treatments or therapies or initiate them, and certainly not without discussing first with your consultant obstetrician. We will discuss in turn the use of tocolytics, antenatal corticosteroids, antibiotic prophylaxis, the use of magnesium sulfate for neuroprotection of the neonate, and finally the issue of maternal transport. Tocolysis may prolong pregnancy for up to 48 hours when given prior to 34 weeks gestation. This allows the window of opportunity to administer corticosteroids and allow effective transfer of the patient to another center. The most common tocolytic used currently is the calcium channel blocker nifedipine, or Adalat. Our current protocol suggests administering Adalat 10 milligrams orally every 15 minutes for a maximum of 4 doses while a patient is contracting and symptomatic. Other tocolytics to consider would be prostaglandin synthetase inhibitors such as indomethacin. Indomethacin can be administered as 100 milligrams rectally and then 25 to 50 milligrams every 6 hours as orally up to 48 hours. Administration of Indocet beyond 48 hours is associated with an increased risk of pulmonary hypertension in the neonate due to premature closure of the ductus arteriosus and therefore is not recommended. Antenatal corticosteroids are indicated in patients presenting with preterm labor and or premature rupture of membranes from viability, which is 24 weeks gestation, up to 32 weeks in the situation of premature rupture of membranes, or up to 34 weeks with intact membranes to reduce the risk of neonatal infection, infant respiratory distress syndrome, necrotizing enterocolitis, and intraventricular hemorrhage, infection, and death in the neonate. Our two currently used regimes are betamethasone, 12 milligrams, administered intramuscularly every 24 hours for 2 doses, or dexamethasone 6 milligrams intramuscularly every 12 hours for 4 doses. Antibiotic prophylaxis. The use of several antibiotic regimes has been shown to prolong the latent phase and safely delay preterm labor in patients with a history of preterm, pre-labor rupture of membranes. Obviously, those patients would have to have preterm, premature, or pre-labor rupture of membranes confirmed with a speculum exam. When performing a speculum exam to assess for rupture of membranes, one would expect to see pooling within the vagina, as well as have a positive nitrazine change. And when the fluid is applied to a microscope slide, you would see the typical ferning pattern on microscopy. In addition to antibiotic prophylaxis for patients presenting with PPROM, antenatal corticosteroids, magnesium sulfate, which we'll discuss in just a moment, and tocolysis may still be required and considered. Current antibiotic regimes include ampicillin 1 gram IV Q6 hours, in addition to erythromycin 500 milligrams Q6 hours IV for 48 hours, followed by a switch to amoxicillin 500 milligrams orally QID and erythromycin 250 milligrams orally QID for an additional 5 days. Alternative regimes include clindamycin as well as ampicillin or amoxicillin alone. We know that babies born prematurely are at increased risk for cerebral palsy and poor neurodevelopmental outcomes. Magnesium sulfate has emerged as a treatment to significantly reduce the risk of cerebral palsy. Magnesium sulfate is useful to be administered to patients at high risk for preterm birth from viability of 24 weeks to 31 weeks and 6 days gestation. The current dose includes a loading dose of 4 milligrams IV given over 30 minutes, followed by a 1 gram per hour maintenance infusion until delivery. For patients who are undergoing a planned preterm birth, magnesium sulfate should be started ideally within 4 hours of the planned delivery. Indicated delivery, for example in an emergent situation, should not be delayed to allow administration of magnesium sulfate. Existing protocols do exist for monitoring after the administration and during the administration of magnesium sulfate, and these should be followed as per your center's policy. And finally, we'll talk about transport. There are several things to consider when you're transferring a patient with suspected or confirmed PPROM or preterm labor. Obviously, you would need to consider the availability of neonatal and obstetrical care, the availability of effective, fast transport and skilled personnel to effect the transport of the patient. The travel time needs to be considered. Obviously, the stability of both the mother and the fetus should be considered in your decision to transfer a patient from your center, as well as the possible risk of delivery en route. Contraindications to transport of a patient with PPROM or preterm labor would be unstable maternal or fetal status, including abnormal fetal surveillance, imminent delivery, where delivery en route would be highly likely, no experienced attendants to effect the transport, and obviously weather. Given our climate and the degree of distance some patients have to travel to get to the higher level center, weather is a serious consideration when working and managing patients in rural Newfoundland. When a patient presents to your center with suspected or confirmed PPROM or preterm labor, we would expect that she would be considered high priority and assessed and examined expediently. These patients should be assessed and managed as an obstetrical emergency. As you know, at Central Newfoundland Regional Health Centre, there is always a consultant obstetrician as well as a family physician on call for obstetrics. When you are seeing and assessing these patients, these high-risk patients, in your local emergency departments and clinics, please do not hesitate to contact either the obstetrician or family physician on call for obstetrics to effect immediate transfer of your patient for assessment at the higher level centre. We would hope that in the ideal world, all moms presenting with preterm birth would have time to be transferred and managed at a tertiary care centre, as we know that outcomes for both moms and babies are improved at the higher level centres. In the real world, we know that this is not always the case, and there will be times when delivery is imminent and you will have to manage the patient at your local centre. It is our hope that as you continue through this course, you will learn and develop the skills to be able to deal with the patient who presents to your centre with a true obstetrical emergency, such as PPROM or preterm labour, to be able to manage them effectively and safely. Thank you.